Hello everyone. Today we'll be talking about role of ionotropes in acute congestive heart failure. Please review my earlier lecture on how to decongest patient in congestive heart failure. One of the biggest limiting factor that you will see in congestive heart failure is renal blood flow. Low renal blood flow contributes to sodium retention by multiple ways. It limits sodium filtration. It increases sodium reabsorption in PCT. It reduces renal delivery of salt to the proximal tubule, thereby stimulating renin-angiotensin system, and certainly decreases delivery of diuretics into the tubules. And all these factors will decrease sodium loss. So you can increase the renal blood flow, and to do this, you typically use inotropes such as dopamine, milrinone, dobutamine, etc. Some of them, such as milrinone, levosimendan, and SERCA2 modulators, also have lusitropic effect. That is, they increase ventricular relaxation as well. Since there are a lot of studies and nuances to use of inotropes, this is going to be a relatively longer lecture. My suggestion would be to increase the speed to 1.25 to help you go through the contents faster. So let's talk about these inotropes in more detail and their role in acute congestive heart failure. In this lecture, we'll understand what kind of inotropes or contractility agents you can use in acute congestive heart failure to improve decongestion and see if one is better than other and look in evidence for their use. We'll also discuss some newer drugs to improve the contractility. We are talking about severe congestive heart failure. These patients are congested but do not reveal any sign of hypoperfusion. So these patients are cool with normal lactate and borderline blood pressure. And in these patients, you would usually use vasodilator, decongestive therapies, and goal-directed medical therapy if tolerated. If these patients worsen, they will start developing signs of hypoperfusion, which will be seen as end organ dysfunction. This constitutes a different diagnosis, that's your cardiogenic shock, and in these patients, you would use inotropes and pressors. In this lecture, we'll stick to the use of inotropes in severe congestive heart failure. The first drug is dopamine. Dopamine has differential effect depending on amount that you use. So in low doses, it stimulates your dopamine 1 and 2 receptor, which are present in splanchnic and renal vasculature and causes vasodilation and therefore improves renal blood flow and causes decongestion by vasodilating splanchnic circulation. In higher dose, 3 to 5, it stimulates beta 1 receptor resulting in chronotropic and inotropic effect, and at doses more than 5 micrograms per kg per minute, it stimulates your alpha 1 receptors, causing vasoconstriction. Tachyarrhythmias are more frequent once you exceed the dose of 10 micrograms per kg per minute. Dopamine has been shown to improve the urine output. However, it has not been shown to improve mortality. This was a large meta-analysis done in 2005, and you can see that patients with different population and different needs, dopamine was unable to show improved mortality. So let's see the effect of dopamine, especially in acute congestive heart failure settings. Rose acute heart failure trial used dopamine at 2 microgram per kg per minute for 3 days, but did not find any increased urine output in first 72 hours. In a subgroup analysis, there may have been some signal of its working better in lower ejection fraction and lower blood pressure. DAD-HF2 trial studied acute congestive heart failure, found that low-dose Lasix plus low-dose dopamine did not differ in outcome when compared to high-dose Lasix or low-dose Lasix. The urine output at 24 hours was not significantly different in the 3 groups. A meta-analysis of low-dose dopamine in the heart failure showed that it does improve the urine output somewhat. However, it did not improve mortality or readmissions. Supporter of the low-dose dopamine still suggests that maybe we should have used higher dose up to 3 to 5 micrograms per kg per minute, as at this level it also has inotropic and chronotropic effect. However, we do not have answer to that question yet. You will see that stimulating beta 1 receptors in congestive heart failure in our subsequent slide does not lead to improved outcomes. Milrinone is a phosphodiesterase 3 inhibitor with half-life of 2 to 2.5 hours, and it's present in cardiac sarcoplasmic reticulum and smooth muscles, where it vasodilates arteries and veins, and in the heart, it increases contractility and also increases calcium availability in myocyte sarcomere, improving myocardial relaxation. It is metabolized in the liver and excreted in the kidneys, so it should be avoided in ESRD patient and acute kidney injury and dose adjusted in CKD patients. PROMISE study used oral milrinone in severe chronic heart failure patient. Unfortunately, it found that there was increased mortality and morbidity in patients with severe chronic heart failure when given for a long period of time. So to see the effect on acute heart failure, they performed Optime CHF trial. Here the mean LVEF was 23% and they compared 48 hours of milrinone versus saline. They did not see any difference in death or readmission or length of stay between the two groups. However, in the milrinone group, they saw more adverse effect, especially new atrial fibrillation or flutter and sustained hypotension. The authors concluded that there was no indication of routine milrinone use in acute CSF exacerbation. Inoximone is another phosphodiesterase 3 inhibitor and it was studied in essential trials. These randomized around 1,854 subjects with EF of less than 30% but failed to see any effect in mortality or 6-minute walk test. A meta-analysis was done for role of milrinone in acute heart failure after acute myocardial infarction, and it showed that milrinone does increase cardiac output, however it does not improve the outcomes. At this point, milrinone and other phosphodiesterase 3 inhibitors do not really help with patients with acute CSF exacerbation. Dobutamine is a very interesting drug with half-life of 2 minutes. At low dose, it stimulates your beta-1 receptor in the heart, causing increased contractility and heart rate, and beta-2 receptor in the blood vessel, causing vasodilation, therefore can help congestive heart failure patient. At higher dose, it can stimulate alpha-1 receptor in blood vessel, causing vasoconstriction. The role of dobutamine in congestive heart failure was studied in this meta-analysis. Dobutamine was not associated with improved mortality in this meta-analysis. Whenever you discuss inotrope in congestive heart failure, doctors are at opposite end of spectrum when they discuss dobutamine versus milrinone. Proponent of dobutamine proclaim that it's faster acting, has shorter half-life, and can be used in renal or hepatic failure, while proponent of milrinone propose that it reduces pulmonary artery pressures, improve RV function, and possibly is a better vasodilator, less arrhythmogenic, less tachycardic, and possibly uses less myocardial oxygen consumption. When dobutamine was compared to milrinone in ADHERE registry, they did not find any difference in outcomes between the two groups. They studied a lot of pairwise comparison, especially with the vasodilator and inotropes. You can see that patients on vasodilator therapy perform better than those on inotropic therapy. However, the logic would dictate that milrinone and dobutamine, which are the inotropes, would be used in sicker patients, and that's why increased mortality. They did a propensity scoring matching. However, understand that propensity scoring matching does not remove all the confounding factors because you do not know all the confounding factors. Another problem with this study was problem with multiple comparison. Read about p-hacking and see if you can figure out the problem with this study. However, we have a good randomized control trial published recently which compared milrinone with dobutamine in cardiogenic shock. They failed to see any difference in outcomes or any safety markers, for example, heart rate, blood pressure, and serum lactate level. In a recent meta-analysis, there was no difference between milrinone and dobutamine when they took observational studies or randomized control trials. In a Cochrane database of systemic reviews, there was no convincing data supporting any specific inotrope to reduce mortality in hemodynamically unstable patients with cardiogenic shock or low cardiac output syndrome. So we should stop arguing which one is better. Both seem to be equivalent as per the recent randomized control trial. However, in certain situations, milrinone is better, and in certain situations, dobutamine is better. Milrinone is better hemodynamically than dobutamine if the patient has been on beta blocker therapy, and milrinone should be used cautiously in renal failure patients. The incidence of AKI is up to 36%, so be cautious when you use milrinone in these patients. However, the dose of milrinone can be renally adjusted, so make sure you talk to your pharmacist. Levosimendan is a calcium sensitizer. It binds troponin C and changes the conformation of troponin I, therefore reduces troponin I inhibition on actin myosin bridges formation. Since it does not result in influx of calcium, its arrhythmogenic potential is very low. Its half-life is pretty short. However, its effect can last for more than a week due to half-life of its active metabolite. Early study on this drug showed significant improvement in mortality and cardiac hemodynamics. However, in a subsequent SURVIVE trial, there was no difference in outcomes between dobutamine and levosimendan group. Another two trials, Revive 1 and 2, studied levosimendan versus placebo and did not find any improved outcomes with levosimendan. At this time, levosimendan has not been approved by FDA in this condition. More recently, levosimendan has been used along with dobutamine to see its effect on acute congestive heart failure. However, these studies are small and more data needs to be collected. At this time, there is no clear indication of empiric dopamine, levosimendan, milrinone, or dobutamine in acute congestive heart failure. According to American Heart Association Guidelines in 2022, despite improving hemodynamic compromise, positive inotropic agents have not shown improved survival in patients with heart failure in either the hospital or the outpatient settings. However, it remains an option in a subset of patients with heart failure who are refractory to other therapies or suffering consequences from end organ hypoperfusion like cardiogenic shock. There continues to be lack of robust evidence to suggest clear benefit of one inotrope over another in cases of cardiogenic shock. Digoxin is one of the other medications that can improve contractility by different means. It inhibits your sodium-potassium ATPase, whose function is to keep the sodium out and potassium in. And when you inhibit this transporter, your sodium remains intracellular and now is exchanged with calcium, so you increase your cytosolic calcium levels. This increases the contractility and it also prolongs action potential in AV node. In the only randomized controlled trial, digoxin was not seen to improve mortality in acute congestive heart failure, but it did reduce the rate of hospitalization. This was a large study with more than 3,000 patients in each arm. Subsequently, there have been a slew of observational retrospective studies, and these have reported either improved outcomes with digoxin, worse outcome with digoxin, or no effect on mortality with digoxin. When you understand all these studies, you will see the evidence of prescription bias. In these studies, the prognostic difference between patients which are pre-treated and not pre-treated with digoxin were so pronounced that they could not be appropriately addressed with statistical adjustment for baseline covariates. And this is one of the important things that you have to understand is most of the doctors, including researchers, don't understand statistics very well. Whenever you see observational study, always question its validity. These are hypothesis generating and do not prove the association. Researchers will do propensity matching, greedy matching, etc. to improve the hypothesis testing, but these are not even close to perfect. If you want to read more about modeling, read about R-square in regression models, and this should help you understand the limitations of these tests. In patients on digoxin, the risk of death is independently associated with serum digoxin concentration, with higher risk when the concentration are more than 1.2 nanograms per ml. In a long follow-up study, digoxin was found to have a higher probability of death when compared to those who are not. Similarly, after acute coronary syndrome, more people died on digoxin on long-term follow-up when compared to those who are not. This was a study which looked at Distellis investigation group trial and looked at the serum digoxin concentration and the outcomes. And you can see that lowest serum concentration, 0.5 to 0.7, were associated with the lowest risk of mortality. However, once the dose crossed 1.6, there was increased mortality risk. So why don't we discontinue digoxin if the patient is on it? And there have been few studies which have looked at the discontinuation of digoxin and their outcomes. And they found that discontinuing pre-admission digoxin is associated with poor outcomes. Because of this, American Heart Association Guideline in 2022 writes that clinical worsening after withdrawal of digoxin has been shown. Therefore, therapy with digoxin may be either continued unless there is a contraindication to its use. So, are you doomed if you're taking digoxin? Answer is possibly not. The benefit of digoxin in patient on current GDMT is unclear because the trial was done before the GDMT was initiated. So optimize your GDMT before considering addition of digoxin. And if you are using digoxin, make sure that your serum concentration are between 0.5 to 0.7. If you're already on digoxin, continue the medication unless there is a contraindication to its use. Omecamtiv is one of the newer drugs. It's a myosin activator and binds to allosteric site on myosin, therefore stabilizes the liver arm of myosin and renders it primed. Priming of the myosin molecules result in increased number of heads available for cross-bridging, therefore it generates more contractile force. So you can see in this picture that there are only 3 cross bridges without omecamtiv, and number of cross bridging increases when you use this medication. Atomic HF study was the first to look at this drug using different dosing pattern, and you can see slight improvement in dyspnea score. However, it did not reach significance. However, the patient tolerated this medication very well. Galactic heart failure trial has been the largest to study this drug. They show lower incidence of composite of a heart failure event or death from cardiovascular causes when compared to placebo. However, when you look at only cardiovascular death, this did not meet any significance. So one of the takeaway from this study is make sure that what are the real outcomes that you are interested in when you read a randomized control trial. The ESC Guidelines in 2022 still show that there is an evidence gap and more research needs to be done on this medication. Similarly, the European Guidelines have not licensed its use in heart failure patients. SERCA2A is responsible for sequestering cytosolic calcium back into sarcoplasmic reticulum during diastole. Therefore, it allows for efficient uncoupling of actin-myosin and subsequent ventricular relaxation. However, this molecule is downregulated in CHF. Using SERCA-A gene therapy, you can increase the number of SERCA2A channels in the heart, and this should be able to sequester the calcium back into sarcoplasmic reticulum. CUPID 1 and 2 trials were designed for this. However, they did not see any improved clinical outcomes in patients with reduced ejection fraction. Istaroxime is activator of SERCA2A pump. Therefore, it improves the relaxation of the cardiac muscle fibers. It also inhibits the sodium-potassium pump, therefore increases the cytosolic calcium level and increases the myocardial contractility. Early studies have shown improved diastolic and systolic cardiac function markers without major cardiac adverse event. You can see that few studies on this drug show improved cardiac index and decreased left ventricle and diastolic volume. However, this is still early in the trials. No comments have been made on this drug in European or American guidelines yet. So finally, what is the role of inotropic support in congestive heart failure? As per AHA 2022 guidelines, the role of inotropic support in congestive heart failure should be limited to patients awaiting mechanical assist device or cardiac transplantation. It may also be considered as a palliative therapy. European guidelines are a little bit more lenient. They also allow its use in congestion refractory to diuretic therapy. So to summarize, there is no role of routine use of inotropes in acute congestive heart failure except those awaiting transplant or mechanical device. You can sometimes use them in patients with congestion refractory to diuretic therapy and low blood pressure in whom signs of shock may develop. Low dose dopamine is not recommended for improving renal perfusion. Higher dose have not been studied but will likely not be beneficial. Despite improving hemodynamic compromise, positive inotropes have not been shown to improve survival in heart failure patient in either hospital or outpatient setting. If there is evidence of organ hypoperfusion, that is cardiogenic shock, inotropes seem to have equal efficacy. Use it as per your comfort, patient needs, and availability. Digoxin is not useful in acute CHF exacerbation and may be only tried once your GDMT is optimized. If you do want to use it, make sure your target serum level is between 0.5 to 0.7. However, avoid stopping digoxin if your patient is already on it unless there is a contraindication. Newer drugs such as omecamtiv and istaroxime is yet to be defined in acute congestive heart failure. These are the references. Thank you.